Thank you very much, ladies and gentlemen. I'd like to call a meeting to order at 6:30. Just to remind everybody, the meeting is planned to start at 6:30, which we are. We're also planned to finish at 8:30. All things being equal, it's my job to keep us to time and make sure that everything goes according to plan. My name's Andy Wright. I'm the independent chair of this meeting, so I don't work for the NHS, and I'm not from the area, in case you hadn't been able to pick up the slight accent. I am an outsider, so I'm completely independent in this, and my job is just to make sure that the panel answer the questions and everybody in the room gets the opportunity to speak. Before I do that, and introduce the topic, I am very conscious that I need to address the...
Hello everyone, I'm Dave Hoxton, Minister here. I know most of you have heard this before, but in the event that the fire alarm goes off, there are no fire drills planned, and we do have an alarm and it's a piercing noise. You will know when it's going off. That wasn't it there. Just to say that you need to, there is nobody upstairs, so it's leave by the doors you came in. And please gather on the plaza opposite where the public toilets used to be. If you gather there, we will make sure everyone's safe. So please leave as calmly and as quickly as you can. Thanks very much.
Thank you, Dave. Right, okay, so now the people on that side of the audience need to shout a bit louder so I can hear you. Apologies for that noise. Right, so today we're here to discuss the future of healthcare in West, North and East Cumbria. This document is available. It's also, there are copies available for you to take away. It's really important that you have a look at this because it not only tells you the options, but I would encourage you to read it because it gives you the website address where all the consultation documents and all the other information is available. So that if you need to get some additional depth, please look at that. Okay, some additional domestics. There is an induction loop, so people sitting downstairs, anybody that's reliant upon that, if you switch your hearing aid to that setting, you should be able to pick us up. We also have Fiona with us, who's our British Sign Language interpreter. Now, it's a very challenging role to actually interpret for 2 hours and to interpret for 2 hours accurately. So I'm just going to ask Fiona to sign to the audience to see if there is anybody that requires her services, and if there isn't, I'm going to stand her down. Okay. Now, what I'm now going to ask Fiona to do is to go to the back of the hall and to greet anybody to see if anybody comes in that requires that interpretation, in which case she will come back into service. And I'd just like to thank her for the time. All right, thank you. Consultation today. This event is about a two-way dialogue. It's very important that you get the opportunity to say what you want to say, and that's what I'm here to do. But it's also important that we let our colleagues from the panel have their opportunity to answer your questions. So I'd like to just say, and I don't believe in massive ground rules, but for this event, I would really appreciate it if we talked, if we treated each other with respect, we allowed people to finish their questions, and also just listen to what's going on. And I'll also ask the panel to listen to that. I'll also ask you to keep your questions concise because we have a lot of people here today who have a lot of questions, and I'd like everybody to have that opportunity. So the longer you take for a question, the less time other people have to ask their own questions. Also, panel, please be concise in your answers and make sure that we get to what we need to do without spending too much time. The format will be, we'll have a short presentation. I've been promised no more than 15 minutes. And then we will come back and open the floor for questions and answers. And I will manage that, and I'll just tell you some more details around that. So, my name's Andy Wright, independent, as I said, and I'm employed by the Consultation Institute to do this role today. And what I'm going to ask now is if the panel would introduce themselves and their role, and then we're going to finish with Stephen Eames, who will give us a presentation. Thank you.
Hi everybody, my name's Claire Malloy. I'm the Chief Executive of Cumbria Partnership Trust. We're the organisation that runs community services, including community hospitals and mental health services across the whole of Cumbria.
Good evening, I'm Anna Stabler. I'm the Deputy Director of Nursing, Midwifery and Allied Health Professionals at the Acute Trust, and I'm a registered nurse and midwife.
Good evening, everyone. My name is Stephen Childs. I'm the Chief Executive of NHS Cumbria Clinical Commissioning Group, and it's the responsibility of the commissioning group to oversee the consultation process, and ultimately the governing body will make the decision when it considers the recommendations in 2017.
Hi everyone, I'm Rod Harpin. I'm an anaesthetist, intensive care specialist, and also medical director at the Acute Trust.
Hello, my name's Matt House. I'm a consultant paramedic with the North West Ambulance Service.
Hi everyone, I'm Stephen Eames. I'm Chief Exec of the North Cumbria University Hospitals Trust, and I'm going to go on to the presentation as our chairman said. If we could just skip over the first slide actually, because Stephen's explained, I think, the responsibility of the CCG in his instructions. Just to cover a few other points important points about the consultation process. No decisions have been made and nothing's predetermined in this process. So this meeting and on all the others that we're having are extremely important. And what we're here to do, and I'm glad our chairman outlined this at the beginning, is spend most of the time listening to you, responding to your questions obviously, but these sessions are being recorded, so every single point that's made contributes to the consultation. All of that will be analysed independently and made public once that's all been done. I think it's important to make the point, because this has been unclear in one or two places, this is not a sort of a vote on the issues, and there's no veto on them over any of the changes that we may in the end move towards. But having said that, what we want is a significant engagement with the public about these challenging issues that we face, which moves me on to the next slide. Just a little bit about the background around those challenges. I recognise a lot of faces, so you probably heard quite a bit of this before, but for the people who've not been here, it's important to cover the ground. If you look at population health, the indicators around the health of the population here, we've got some very big challenges. If you look at some of the indices compared to other parts of England, there are very significant challenges here for us all to respond to, particularly in the health service, but in social care, and also the public and our communities. And I know people are working very hard on that. We've got significant difficulties attracting doctors and nurses. It says doctors and nurses. Actually, you could extend that to other groups of important professional staff who work in the NHS. Today, I just checked it before I came here. There's nearly 100 people in our hospitals in Whitehaven and in Carlisle who actually, if there were alternatives, wouldn't need to be there. And that's at the centre of the strategy that we're pursuing. I mean, it sounds a bizarre thing to say, but if we were able to treat those people in different ways, we've got too many hospital beds in West, North and East Cumbria. But it's true, if we were able to change that. And I would challenge anyone in this room to want their relative, loved one, to be in a hospital bed when they don't need to be there. So that's a big challenge for us running the services, and central to what we're trying to achieve here. We're overspent. It's a big financial problem. I won't labour the point, but it's something we have to address. And we also know that our regulator, the CQC, the Care Quality Commission, have indicated that some of our services, in the way that they're organised currently, are inadequate. And we have to do something about that in response to our regulator and to improve the quality of our services. So if you move on to the next slide, this slide is really making a point that a lot of people, and I've heard it in these meetings, a lot of people have made to me all the way through this discussion about uncertainty. Absolutely, it doesn't help. And there is a lot of uncertainty as we go through this process of change and consultation about where the final picture and decision is going to land. I think it is the responsibility of people like myself and colleagues on the panel to end what's been, in my judgment, from the limited experience I've got in this part of the world, long-standing issues that have remained unresolved. And that's what we're trying to do. They're very difficult issues. If they were easy to solve, we would have solved them. But I think we're at a point where it's important from the community's point of view and from the providers and commissioners of health services locally to end this period of uncertainty decisively once and for all, and that's what we're trying to do. We need your help in doing that. That's what this consultation process is about. I'm not going to go into the detail, but I should make the point that a lot of the feedback we've had thus far, there's a councillor in the room somewhere, I think, who spent 2 or 3 hours today talking to us about this very challenging issue around travel between our sites. And that's bringing new information, new insights into our thinking. And I think that's been a really brave stance that's been taken on behalf of the public, and one that we're taking on board. We do have a clear vision, though, in setting out the future. It's there hopefully on the slide behind me. You're following me, good. And that's it. I won't read it out, but I think we have to turn some of our perceived weaknesses about being in a rural setting, and perhaps we've got isolated communities and it is difficult to provide services, into a strength. What we need to do in this part of the world is create a centre of excellence for rural medicine and care, and also support that by academic infrastructure. And you might say that's a load of words. Well, it's not actually. We've got a lot of investment going in to support that vision. 2 professors, one in primary care, one in medicine, one coming up in surgery, so that will be 3. Significant investments in training staff. You know, Whitehaven, which is at the heart of this, at the West Cumberland Hospital, next February, we'll have 25 people who have joined us to train as physician associates. And these people are vital to providing local services in the future. So that vision is turning into reality, and we've got a lot more to do, but that's a very significant start. Probably the most important part of what we're looking to change over the next few years actually isn't being consulted upon. It's about the delivery of integrated care communities. There are 8 intended across West, North and East Cumbria. And it's fundamental to the way in which, whether we're in Cornwall or in West Cumbria, we need to change the National Health Service. As much care as we possibly can needs to be provided in people's homes, locally, and ideally by community-based staff supported by the specialists in hospitals and specialist centres. That's a massive change, and that's really at the heart of what we're trying to do. If we can achieve that, then access in all sorts of ways will be better for the people that we serve. Can we go on? Sticking to the time scale. So in summary, I'm just going to quickly summarise in a second the options that are in the consultation document. But essentially what we're trying to achieve by this range of changes in that set out in that document are safer services, better quality services, services that are here and sustainable for the long term. I mean, at the moment, and I've spent 40 years working in the NHS, some of the services here are really fragile because they're dependent on temporary staff. And that's not a sustainable position. We have to solve that so we can improve the service for local people like yourselves and others. And we have a duty, like all public bodies do, to ensure that we run a sound business, that we're financially stable. So if I can go on to the potential service changes that we're consulting on, and I know many of you will have studied these in detail, but just to go through them quickly, children's services, and the purple type on the slide is the preferred option. People get caught up in this debate about, well, you've got a preferred option, so that must be what you want to do. Well, actually, we are duty-bound in a consultation process under the guidance to give a preferred option. It doesn't mean to say that that's the one that we actually end up with when we've completed the consultation. If it was, and I've done many of these, by the way, and it never is as it starts, it does change through the process. I suspect we'll see some changes as a result of your input and all the other inputs we're having across the discussion over these past few weeks weeks, in the next 5 or 6 weeks. So on children's services, there were 3 options set out in the document. The preferred one is to keep inpatient services at Carlisle and at West Cumberland, but we would have a lower risk service for inpatient children at West Cumberland. And in both cases, we'd be establishing a Children's Day Assessment Centre. Now, this is a national model of good practice. We know that in introducing that model, we would reduce hospital admission. That's the preferred option. The other options, I think, speak for themselves. I think in the interest of time, if everybody's happy in the audience, I probably won't go through them because it will make sure we hit the 15 minutes, but I'm sure we'll come back to them in the discussion. So if I move on to maternity services, there are 3 options there. We've had lots of discussion, and this is one of the biggest issues I know from what's been going on in the consultation to this point. The preferred option that we've set out is a midwifery-led unit at West Cumberland Hospital with a consultant-led unit at Carlisle. And the other 2, I think it's probably important to make the point about the first option, because it's not always understood that even in the first option, if you had 2 consultant-led units, actually the profile of the deliveries or births going on there would change as a result of national best practice guidance. So some complex care would move to Carlisle, relatively small numbers, albeit under that particular model. If we move on then to community hospitals, there are, sorry about the microphone and I need 3 hands. There are 4 options, again, you can see from the documentation. The preferred option is consolidation on 6 hospital sites. That reduces the bed numbers in total across community hospitals in our area. I think it's by 2029, 30-something of that order. I really want to make an important point here that we're not talking about closing community hospitals. We're talking about redesigning, in partnership, particularly with social care and with other agencies, the way in which our community hospitals are utilised as part of that vision that I was describing earlier on. If I can move on to emergency and acute care, our preferred option there seems to chime this one with the public, is for a 24/7 accident emergency service to continue to be provided at West Cumberland and at Carlisle. And then if we go on to the next one, which is essentially stroke services, the last thing I want to mention in terms of the options. 2 options there. What we want to move to is an internationally recognised model, and one that's recognised nationally, that saves lives, by creating a hyperacute stroke service and facility at Carlisle with a supporting infrastructure. The details are set out in the document in the West Cumberland Hospital. On to the penultimate slide. It's about the money. Again, I won't say a lot about this. We are overspent at the moment. We have a duty to bring that back into balance. What we're saying is that if we are not able to deal with that overspend, we'll be overspending by a much larger figure by the time we get to 2020. We've got a series of detailed plans to address that overspend, but actually we're only going to be able to do it if we can deliver some of these changes that I've been talking about. Particularly, it's important to really note, because this gets missed when people talk about the money. We're talking about spending our money differently. So there's a big chunk of around about 40 million, which is going from parts of the service, from secondary care services, hospital services, into the integrated care communities. A big translation. Of course, money equals people in our business, so that means a big shift in focus in the way that people work and where they work. Vital to that future vision. A simple last point on this is, if you take the range of acute service changes that I've touched on and that are in detail in the consultation document, that only saves 2.6 million. Those changes are not about the money. They're about quality and sustaining services in the long term for all the people that we serve. So just on the last slide, and particularly as we're here in Whitehaven, I'd want to make some really important points before I hand back to our chair. Anybody that thinks there isn't a future for West Cumberland Hospital is wrong. We've spent 100 million as a National Health Service on building a new hospital. We are spending £10 million now on the hospital, improving services. And that 10 million, part of that is being spent on bringing more surgery back. We're already doing that. We're bringing trauma back. We expect to do an awful lot more of that over and above what we've already done over the next 12 months. We're building a new diagnostic suite, vascular surgery, cardiology, breast care locally. And the final point is we will be treating within the next 12 to 15 months more people than we've ever treated in Whitehaven locally. At the moment, if you take 50% of the people from this area who go to Carlisle for assessment, treatment, diagnosis, 7,000 people, 7,000 more patient episodes. And just think, oh, clearly, if we were able to improve on that, which is what we want to do, that's even more significant. So whilst I completely understand the heartfelt concerns that people express, I'm sure tonight, and expressed elsewhere, about the things that are changing. This isn't running down the hospital. This is spending money and bringing more care back locally. Okay, I'll hand back to the chair.
Thank you, Stephen, for keeping to time. A couple of important points to say before we get into this. The first, Stephen mentioned that we are going to be audio recording this. And it's very important to say that this is the way that the information will get fed into the consultation. So what I'm going to ask, or what I'm going to work with my colleague, Tom, who will have a microphone, please make yourself known that you want to ask a question. Wait till Tom gets to you with, and I'll indicate who we're going to, in the order in which we're going to take the questions. Tom will come to you, and it's really important that you wait till the mic gets there so that we can record everything. Simple point around this is that community consultation or any form of consultation, it's really important your voice is heard. If you don't speak to the mic, we won't hear you, and you might ask the most important question tonight, or you may make the most important observation. If it's not recorded, it doesn't get into the evidence. So please bear with us while I give an aerobic session to our colleague over there. I'm going to take questions in groups of 3 and ask the panel to respond to it. And before I do that, we've got some people standing at the back. There are some spaces around the front. Are you comfortable at the back? Okay, I don't want to leave you standing there without asking. Thanks very much. Okay, so yeah. Yeah. Sorry, the audio recordings, the question was, for the record, are the audio recordings going to go onto the website? They are, saying they haven't been updated since May. I think if you talk to me later, I think there's an issue around the particular website that you're looking at, and we'll sort that out, and we'll make sure that that's available. Okay, thank you. Valid question though. Right. Okay. So to business. First question. So take the first set of if you can let me know. And when you ask the questions, if you want to give your name, that's fine. If you want to remain anonymous, it's also anonymous. Yeah, anyway. I'm going to say gentleman here, lady here, and this gentleman, and then we'll respond.
My name's John Mossop. Could you tell me if any of you people were involved in putting the business programme forward for the new hospital? To get the money, the planning? No?
Okay. Yeah, we'll get the response.
This is just the first bit of it.
Yeah.
Because in the business plan, to get the money off the government, when it was put forward, the government agreed to fund a new hospital, and the final lines on this was all services to be retained. We're only halfway through the new build, so I can't see how it's changed that quick. This services, each time you move them from Whitehaven to Carlisle, all them services had people there. It's no good saying you couldn't get staff. When you move a service, if I go into hospital or you, the funding for my treatment goes with you. Then you say, West Cumberland's unsustainable. You are running it down, you are making it unsustainable. You can't be halfway through a new build and the government agreeing, and when it said to keep the services, it also said within a few years, 3 or 4 years, West Cumberland would be in profit. Now, everything you've said this meeting, the last meeting, goes against what was agreed. It's a contract between you as a health service and the government to get the funding.
Okay, thank you, John.
You've agreed the contract.
John.
Under them.
I think you made your point now. Can we just move on to the next question? Really good point, and I'm going to put the panel to that question. Lady here, please.
Good evening. I'd just like to ask you about the services at West Cumberland. I'm booked in to see a cardiologist on the 15th of December. Apart from that, I've had 2 letters from Morecambe Bay Hospital to ask me to go down there for exactly the same thing, bearing in mind I live right across the road from West Cumberland. Because I'm disabled, they would give me free transport there and back. That's 4 times. Do you think that's right?
Yeah, thank you very much for that. And the gentleman here.
Thank you. My name's Chris Whiteside, and my question is I would like the panel to please take away and think about, and by all means respond to, the following reasons I would beg you to reconsider on maternity, going for option 1, consultant-led maternity, rather than a midwife-led unit. You say rightly on page 19 of your consultation document that the assessors from the Royal College of Obstetricians and Gynecology recommended consultant-led maternity at both as their preferred option. One of the things you haven't mentioned here, but I'd like you to think about, please, they actually said in their report that before they visited Cumbria, they had expected to recommend a single maternity unit for the whole of Cumbria. But when they actually came here and saw things like the roads, they changed their minds. And the sort of reason why I believe they did that, if you look at the 30 miles across terrible roads between here and Carlisle, and you consider the fact that there are some women giving birth, such as crash caesareans, for whom there is a very urgent need for very rapid treatment, such that a midwifery-led unit cannot provide, I believe there is a serious risk to those people if you go with your current preferred option too. My final point is, I think it's so important to address the issue of recruiting people, to be positive, and that goes both for the panel and for us. We don't want to give negative signals when we're trying to recruit people. I was very pleased, Stephen, to hear you refer to the excellent work that's being done with the university to create more training. I think it's really important that you promote that hard to make it easier to recruit more doctors, nurses and obstetricians by building up the status of West Cumberland Hospital.
Thank you very much for that. Okay, thank you very much. I'm going to ask the panel to respond to that, but also to make you aware that we have other colleagues from NHS who may be called on to answer some of the technical questions as they come through. So, first question about Whitehaven, West Cumberland. Sorry.
Yeah, if I could start with this, other colleagues might want to come in about your question. It doesn't quite work like the way that you've explained it, but I understand how you might feel that way. The money that we have is for all of our services, whether it's at Whitehaven or whether it's at Carlisle. So if services change, either way, the money still remains here for the local population. I think it's important to get across in this context. Lots of people from this area, as I was pointing out, use our services in Carlisle. Lots of people actually from the Carlisle Island use services at Whitehaven, and more of that will happen. So we're providing a service to the whole community. We don't look at our hospital budgets or anything else in isolation. I think you're right. I was looking like I can't see if there's anybody in the audience who was actually as well who was actually here when the original hospital was planned. I don't think there is, unless anybody's going to shake. Oh, David is. So I'm going to ask David to perhaps say something briefly, if you wouldn't mind, David. The only thing I would say about what, obviously, in healthcare, like in any other walk of life, things change all the time. Techniques change. What we did in hospital 5 years ago, we can now do in the community. In Whitehaven Hospital today, there are people having knee operations and leaving at the end of the day, unheard of 6 or 7 years ago. Hip operations within 24, 48 hours. So that changes the nature of the way in which you use our hospitals all of the time. But David, would you mind mentioning something about the history? Is that okay?
Hi there, I'm David Rogers. I'm from Cumbria CCG. I'm one of the few people who have been around long enough to remember this. The services, yes, the services that were planned at West Cumberland were the range of services that were being provided. So that was maternity, paediatrics, and that new build has been there, and then there's a refurbishment planned, which has been looked at. The problem that we face is really around the significant change in staffing that has occurred since the plans went in and since the hospital was built. So the real pressure point is around the ability to safely and sustainably staff it. And I was also involved in the RCOG review, and you're quite right to point out that Tony Faulkner said exactly what he said. What he also said is that if we can't safely sustain it, then we need to look at other options. And it's because of the staffing issues that we're having to start to look at some of the other options. It's not a desire to not have option one, it's the staffing that's the problem.
Well, you want to change the revenue that's already led by a consultant. All you're doing there is down.
Sorry, John. We'll come back to you. If you've got another question, we will come back to it. But we've got other people who are waiting for responses to their questions. Won't forget that you want something, but we'll just move on to the next question, which I believe is the question about what services in Morecambe Bay.
Well, the cardiology question, all I was going to say to you about that, rather, is that I don't know what your condition is, and I don't think we should go into that in front of everybody here. But to my mind, we just need to pick up with you afterwards what the situation is. I'm sure we can look after you locally, but let's deal with that outside the meeting if that's all right.
Okay, and the third question from Chris about maternity services.
In a way, I think David's half answered the question, the progression from the Faulkner, the Royal College of Gynaecologists report, the recommendations of that, and it's reasonable to say that that did say that the preferred option was to keep 2 CLUs working. It is the preferred option of our obstetricians and gynecologists. But there is also a recognition that if we can't sustain that in a reasonable form, and we're trying to sustain 2 of the 7 smallest units in the country, CLUs, that presents us with particular challenges. And what the Royal College of Gynaecologists report with Tony said, that there would be a year of intense work, which has gone on with the CCG and others, attempting to put together a proposal that would keep the 2 CLUs going, and that didn't come to fruition over that year in a way which could see a sustainable way forward, which would satisfy our regulators and us that we weren't going to have an on-off service. So that's the way that panned out. I would add something at the end of that, because I'll pick up the point about recruitment, and it is about being positive in both directions. And one of the things that absolutely destroys our recruitment is, one, the uncertainty, and having processes going on which seem to be negative to a young consultant wanting to move to the area, or a young doctor. And this isn't just about hospital services, it's about general practice as well. And secondly, I think having negative ratings with the CQC and others, really people don't want to move to an area where they see the health services as not giving them a future that starts off well. They want to work with reasonable groups of other consultants and want to work in a trust and a health environment that's succeeding. So it is a two-way process.
There was another comment about the road network between the 2 points as well.
Yeah, and I think that comment's been well made from a number of meetings I've been to, and we don't have the best of road networks.
Okay. Thank you. I'll take 3 more questions again. Yeah, I will get to you all. Just give me some time to get around. So, with the gentleman at the front here, and okay, fair enough. We'll take it one at a time. But the onus is on the people in the audience to take it to be as concise as possible and not to make the point too eloquently, because we find the balance between that and getting everybody heard. So point taken. I'll go to single questions as long. Yeah. The point's made, and I understand it. So we're going to take the gentleman here first, then I will get to everyone at the back. Yeah.
I remember the first meeting ever we had with Sir Neil, and there was a discussion about some relaxation of the guidelines from the Royal Colleges. And I think we need to find out what was the outcome of that discussion. The other point I would like to make is...
Well, hang on, we've just been asked to stick to one question, so if you stop it there, and I'll... Okay, fair enough. Carry on.
Thank you. The other point is, important point is, if the integrated care community changes is 3 to 5 years, why sustainability is only 1 year? We need to give 3 to 5 years to retain and recruit the new staff. The 1 year is not enough. And finally, I would like to ask the panel, what is the unsafe distance they consider would the mother to be cannot travel?
Okay, so we'll take the first question about the relaxation.
Yeah, I mean, Rob might know. Sorry, it's your microphone. I want to take your microphone. It might be, just going back to your point, it's very helpful. It might be other people might need to chip in from the panel on certain questions. This might be one of them. But in the context of Royal College standards, Royal College standards are guidance. And you know this because you're a consultant, so you know the answer to your question, actually, Mesh. But just to sort of play it out for everybody that's here, it's guidance, and we work to guidance. We can't always hit it. The issues are not driven by, I mean, I don't know about that debate, it wasn't something I've been involved in, but the issues are not driven by the Royal Colleges. The Royal Colleges actually do make recommendations that we strive towards. The issues are driven by clinical standards set in national policy and set by the Care Quality Commission. Now, we cannot relax those. If I relax those, I am failing in my duty to the public, as is my board, as is Claire's board, anybody else around this table. So we can't do that. That's the answer to your first question. I'll just make a comment about the sustainability point and integrated care communities. I don't know, Stephen, you might want to say something about integrated care communities, and we've got some clinical colleagues who might be able to do that too. The sustainability point is about some of our acute services that are fragile. We're running a children's service with only 0.8 of a consultant. It's not a sustainable position. We have to make changes to that, and we can't wait for 3 to 5 years. We have to be dealing with that now. And that's why we're trying to do it in a constructed way, and a constructive way, should I say, through the consultation.
Mahesh, in terms of the integrated care communities, I think to realise their full potential will take some time, but many of the services that we want to integrate are already there in the community, be they mental health, be they social care, be they general practice primary care. And we've spoken at some length in many previous meetings about the need to do it differently this time. So we have had many attempts in the past to integrate these services, but what we've never had is that commitment to all of the parties that serve a place or a community having the freedom to invest the resources as they see fit. Unfortunately, it's been individual organisation driven, and that's what's fundamentally different this time round. So we can actually realise many of the benefits that we envisage for our integrated care communities quite quickly, but the full potential will take more time. I don't know if we have Dr. Colin there. Colin, would you like to say any more to that?
My name's Dr. Patterson. I'm a GP in Carlisle. We've been thinking hard about how we could bring people together who previously had been working in what you might call silos, which you might call your surgery or your social service department or your community hospital or community teams. It's very, very difficult to give up the way you have been working in the past and come together to work in an agreed way. It sounds easy, but it's very difficult. I think that we need a space to permit this to happen where people can actually be open with each other about the real barriers when it comes to giving care. And I think that we need some way to progress towards having a single patient record, some way of enabling the teams to be coordinated so you don't get multiple visits, multiple records. This sounds easy, but it is difficult. And I think that the integrated care communities have great... they basically are going to be owned by the people who are working in them in cooperation with the communities they're providing services to. And I think, again, we all are looking at this and saying the practice will change, social services will change, community. I think what fundamentally has to change is the interaction between these teams and the communities they serve. And I think that what I'm looking forward to is the time after the consultation. It's the time when things are a bit quieter. It's the time when we can actually sit in rooms together and say, what is best for our community? What does our community want? And I know at the moment this seems a distant time away, and it may be that you're not ready for that conversation until other questions are answered. But I think that when we get to that point, I think people will be impressed about how the tenor of the conversation will change. And I think that, like we are now, you'll find that people will be coming to you and saying, how can we do this better? And I think it's the content of that conversation that will improve how you see this whole process, which at the moment, from seeing folks' questions, feels very threatening. I want to bring Helen in, because Helen is your local GP lead, and maybe some of the stuff I've been talking about seems too distant and theoretical.
Hi, I'm Helen Horton. I'm a GP at Dissington. I'm the CCG lead for Copeland. I think in response particularly to Mahesh's question, I think it's been answered very well. I think integrated care communities are the future, and they are a vision that will expand and grow and develop over the next few years. But, as Stephen pointed out, from a service delivery point of view in the acute sector, especially paediatrics, gastroenterology is another section. There's a lot of very fragile acute services, and we can't afford to sit back and wait over the next 3 to 5 years for the integrated care communities to evolve to sort those services out. As a patient and as a GP locally, the situation in paediatrics locally terrifies me, because we appoint 8 of a consultant. If she goes, then we have a service that is run on locums that may collapse at any time, and that really leaves a gap for our children and our maternity services locally. So we haven't got the time to wait to sort the acute fragile services out, but we need to give the integrated care communities time to develop and grow over the next few years, because it is, as Colin says, it's about changing people's attitudes and changing people's approach to working, and that's going to take time.
Thank you. And the final question about the unsafe distance, I think Anna's going to take that.
Hi, Mahesh. Thank you for the question. I think what I would say is there's lots of work going on as part of this consultation to look at distances and travel. And we have actually got a team down in Wales today, including the MLSC, looking at the distances that they're travelling down there. What we want is to provide a safe service and do what's safe for women.
Thank you. Right, let's have, lady here's been waiting. I'm going to go lady there, young lady there, and I'm going to come to the back. Okay.
Hello, my name's Alison. My daughter had a baby 3 weeks ago, classed as low risk. I mean, what is your criteria for low risk? Because she was a first-time mother. She spiked a temperature, and this was about 9:45 at night, and you want to have no consultants on site. Baby the doctor came in and she had 20 minutes to deliver baby, or baby would have died. Mother would have died because she was bleeding out. We needed through night, she had to have a consultant come in to see her because they thought she'd passed out, they thought she was bleeding out. Baby needed to go to Skaboo because he needed intravenous antibiotics. So what is your criteria for low-risk birth? Because your babies will come at any time. And how can you just say there is no risk? There is a great risk, and we need consultants at West Cumbria.
Thank you very much for that question. Anna.
So as a midwife, I want safe care for every woman. You ask me what guidance you would be using for identification of low-risk women. NICE produce very clear guidance that's used for women to be identified as appropriate for midwifery-led units, and they also provide us with the guidance as to when we would transfer women to consultant-led units. So we would be following our NICE guidance.
Sorry, I know it's a very emotional subject. Can we just allow the answer? And I think picking up from the audience that you're saying that the NICE guidance wouldn't have allowed the time to respond. So I just kind of throw the general audience's comments back to Anna to say, well, how are we going to get around that?
So as women are booked in pregnancy, there's obviously a criteria for when they book in pregnancy to look at risk assessment from right the way from that first meeting and right the way through every interaction with women through the pregnancy at every stage of their antenatal care. When you come into your consultant-led unit or your midwifery-led unit, you are risk assessed immediately and you have some observations taken, etc. We would then obviously be, if it was a midwifery-led unit, we would be looking to transfer women as soon as we identify that there was a risk factor. We would have a dedicated ambulance vehicle on site.
Just allow you'll all get your chance to respond completely. I understand it's very emotional. Just let the response come through, and then I'd like to take all the questions to challenge it, please.
So should we go to a midwifery-led unit, there are plans in place to have a dedicated ambulance vehicle on site, which is purely for maternity services and paediatrics. The ambulance crew will be working in our A&E departments and on our maternity units to maintain their skills and have them available at all the time to transfer women.
Okay, well, hold on. You will get your chance to talk about, and I suspect we're going to return to this issue, and it's a very important issue, and you are expressing concerns, but I'd like to take the questions in the order that I indicated, but you will get your chance to speak, I guarantee you that. Okay, so there's a lady here who wanted to speak.
Good evening. I still don't think you've answered the question, and it's been asked at every single meeting that I've attended, is how low-risk women go, to high risk in the blink of an eye, and if that baby needs to come out in 30 minutes, I still don't understand how you're going to get that lady to a consultant-led service and get that baby delivered safely.
Belinda, and you've asked me that question loads of times, but I think what we're going to do, please, we are respecting your voices, just respect mine. So I'm going to ask Anna to directly answer your question, and I think it'll be a very clear answer. And then I'm going to ask Rod to say something more about that. Before we do that, can I just make an important point here? None of us on the panel think there aren't risks associated with travel between the hospitals. We know there are. We absolutely know that there are risks. The issue that we're facing here is about the relative risks between the three options for maternity. So what you need to think about, which is what we're thinking about when you need your help on, if we didn't have paediatric doctors, you know, Belinda, because you work in this area and you work in the hospital, I know those risks are much greater than the maternity-led unit and the roads. That's the issue. But in terms of the specific, let's Anna speak to that.
Okay, so if you have a midwifery-led unit, you would not have a consultant there on site to call a 30-minute caesarean section, ultimately. So as a midwife, your role as a midwife in a midwifery-led unit is to use your hands, eyes, and your skills to identify when the pregnancy or the labour is not going to plan. And as a midwife, you would then make that call to transfer the woman down the road to Carlisle.
Hold on. You will get your chance to speak, and I'll guarantee that, but just let the answer. And I'll make the points here and now, because I completely understand what you're saying, is that this is a consultation. And it's really important that you get your points across constructively to make sure that the people who are volunteering to take those points have the opportunity to listen to it. So I'll get to them, I will, but allow them to finish, please. And I'll give you the same courtesy. Okay. Yeah. All right, okay. So there's a young lady there who's been has had her hand up very patiently. Just ask her to ask us the question, please.
Hi, my name is Lacey, and I'd like to know, are you going to send people at night, if they have a serious injury or if they're pregnant, all the way up to Carlisle? That is a big risk. Will you do it? I want to know for the safety of the people.
So thank you for your question. Ultimately, yes, because that will be the safest place for them to have their care if that's what's been determined by the midwives or our doctors in the A&E department. So yes, we would transfer children up to Carlisle.
Sorry, again, you're probably making a very good point, but it's not getting into the record. I'm going to throw the questions to the back there in a minute, but just allow the panel to respond.
I was just going to say a little bit to Lucy about transporting people with trauma particularly, and just to make the point that some of the, certainly the outcomes from trauma are very importantly improved by taking people to the right place. And the major trauma has to be managed in that way. Some of our trauma statistics as far as fractured necks of femur improved because we transported people to a central unit where they are managed by people who do it all the time, doctors and nurses and health professionals. So it is important to understand that some outcomes are improved by moving people, and that's been witnessed by some of the improvements in outcomes, mortality, that have occurred with the trauma, fracture neck of femur moves, and the general surgery. And there's clear evidence that those improved our outcomes.
Going back to Anna.
I just wanted to add, Lucy, as well, that we already do... Lacey, sorry. I just wanted to add that we already do transfer ladies sometimes in the middle of the night if they're in premature labour, and they sometimes go further than Carlisle. They go to places like Middlesbrough and Newcastle. Yes.
Sorry
So
again.
if it's So we do it currently at the moment because we don't have dedicated neonatal cots for babies that are really, really small. So they have to go to a dedicated neonatal unit.
Okay, you've made your point very well and completely eloquently. Just to summarise what you said, is that you think that the consultation should be concentrated on buying those things, and that's a point that will be brought into the consultation. Again, I just urge you to make your points into the microphone so that we can get them recorded, but I do feel your passion for that, so thank you very much for those comments. I'm going to take some questions right from the back, if you don't mind, and then I'll come back to the middle. So I'm going to go throw lady there, and then I'm going to go there and work my way back.
Scarf. I'd like to actually ask the consultant paramedic a question. We seem to have an awful lot of problems around here with ambulances. Just ordinary ambulances, never mind emergency ambulances. Emergency ambulances are high risk. And I know that you're failing in the majority of them because I'm actually a county councillor and I actually go through your papers and your statements. So you're actually failing very highly in the red areas at present, which are heart attacks and emergencies. We're talking about a dedicated ambulance here. If we haven't enough ambulances to cover the whole of North Cumbria or the West Cumbria now, where will we get the dedicated ambulance and staff from? And can I just say, will that dedicated ambulance or any other ambulance take an hour? Because I was witness to a fire last Friday and the ambulance had to come from out of county at 11:30 because there wasn't one available in West Cumbria. Now, they can talk and argue as much as they want about services because they'll have one opinion. We have another because we know we don't transfer any ladies that's in labour. Never have done, never will do, Anna. So, but you can't argue every point, Stephen. Come on. But I would like to ask the ambulance man what plans are in place for the ambulance service to cover all this that's going to go on. All this from ICCs, where you're going to actually be transferring and transporting patients from homes to ICCs and back to homes, where you're going to be transferring patients 24/7 in emergency from West Cumbria to Carlisle and back again. Where is all, and do you have sustainable plans for that service? And I know the answer, but do you have sustainable plans for that service?
Thank you. Thank you for that, and I apologise for not recognising you as a county councillor. As I said, I am completely out from outside the area. And I'm going to hand to Matt to answer those very specific questions.
To take your question in two parts, really, we have struggled and we continue to struggle at the moment with our response times, particularly in North Cumbria. And that has been, like the rest of the NHS in North West and East Cumbria, has been down a lot to our staffing. We've struggled in recent years with staffing. We've just had a big input of technicians, and we're currently just doing an induction course. I visited the course today, as it happens, for some paramedics who will go live on duty in January. And on those figures, from April, another 15 paramedics joining us full-time in January. No, this is just for North Cumbria. Yeah. So come April will be the first time in some years that we have full staffing in North, East and West Cumbria. So that will improve things because we will have staffing. So the ambulance vehicles that we have are commissioned to have will be fully staffed. What that doesn't include is the dedicated ambulance vehicle. And we have plans in place. We've looked at the figures. For a dedicated vehicle, we'd need another 11 staff. We've recruited very successfully in the last couple of months, and we would look to have a dedicated 11 staff for that ambulance.
Sorry, can we just wait a second?
Could I just add a point that I think your question raises, which is if, and this is this is a consultation process, but what we're concentrating on is one of the options around the maternity-led unit. If you're in that position and we were planning to, you don't just flick a switch and it happens. There would be a timed implementation process. You wouldn't trigger any change unless you had a dedicated ambulance there with the staff on it. So I think it's quite important to get across. This isn't something that's just going to happen like that. And one of the requirements of the outcomes from consultation placed upon the CCG and ourselves is to tell you, the public, what that plan is. And as you will know very much from your vast experience as a councillor, the Overview Scrutiny Committee would scrutinise that to make sure those things happen. So it's important to understand that you're not suddenly saying it's going to be one thing today and another thing tomorrow. There will be a transition. Just a brief point I think Anna wants to make about what you also said.
Yeah, you said that we never transferred women in labour. I think we've got a number of midwives in the audience that can confirm that we have transferred women over to the North East.
Sorry. Yeah, you're making a valid point, but it's not getting onto the record. So what you're saying is when they're not in labour. So allow Anna to respond. Yeah, okay. So if I could just summarise those points before we move on. It's very important to get them on the record. As we say, this is all about the consultation. So the point you're making is it's unsafe to transfer people when they're in labour, and the point you're making is that they go in a specialist ambulance. Okay. Okay, all right. So those points are noted and in... Yeah, okay. Thank you very much for that. And again, I recognise the passion in the room, and it's really important. I will get to you, sir. I've got a lady who's been waiting at the back for some time.
Hello, my name's Norma Charters. I've been a staff nurse at West for over 40 years. I'm now on 0 contract hours, so I'm just letting you know that I work there. But my point is, I was watching our local news programme a couple of weeks ago when Jamie Reid presented to the Prime Minister the question of her coming up to West to see us and about our denigration of services. What surprised me was she said, in her opinion, Whitehaven did not need a consultant-led maternity unit. On a separate topic, and she said that those issues could be made at local level, which is why we're having the consultation. But on a separate topic, 2 weeks previous, people in Lancashire were reacting against fracking in their area. They had a consultation about it, and the council actually said no, and the government said yes. So my question is, has the decision already been made? Yeah. And can I just say, I've worked in theatre, and I've been at night time on call to maternity, and we've got to the unit in 3 minutes. 3 minutes to do an emergency section. Sorry, I feel a bit, because it's quite...
yes, it is.
Yeah.
It's a very emotional subject.
It is emotional, and I think the people of West Cumbria deserve that service.
Okay, thank you. Point's really well made. So I think this is one of the key questions for the panel to come back to. So what you're saying, what you really, to the nub of it, if I've understood you correctly, are the decisions made already, and is there any point in the consultation? So
thank you for the question, and thanks for raising the letter from the Prime Minister in response to Jamie Reid's letter to her. The wording was interesting, and it was definitely open to interpretation. But what I can absolutely reassure you of is that no decision has been made. Honestly, absolutely no decision has been made. And the point has been stated this evening. It's critical that and that's why we're spending so much time with you in public meetings and a plethora of other ways to take your views is because there may well be changes, as Stephen said, to the preferred options. So genuinely, no decision has been made.
Sorry, I'd just like to correct you. It was actually on Boarding News and Look Around, and it was at Prime Minister's question time. It was a face-to-face issue. It wasn't a letter.
I beg your pardon, I wasn't aware of the face-to-face issue, but certainly I understand the letter followed on.
Thank you. Thank you for that clarification. I'm trying to work my way down towards this side of the room. So lady there with the glasses has had something, and I will come back. Yeah. No, I will get to you, sir.
I've just put my notes away. Sorry. I'm Councillor Rebecca Hanson, and before I ask my question, I just want to pick up on the question that was asked to Anna about transfers, because I wrote a report that was published on transfers last week, and I had a long conversation with Debbie Freak and people today, and we were talking about, people should people know the truth, and I think they should. So the issue with transfers is that if you go in as low risk, is this still working? Yeah. Into a midwife-led unit, the national statistics show that there is a 25% chance that you will then be designated as high risk and recommended for transferal during labour. And that's established, that's what we should expect to happen. And Anna is then right in that she says there's a clause in the NICE criteria which say that the midwife should take a judgment given the distance as to whether it's right to move the mother or not. So they should interpret those NICE guidelines given the distance. The problem we have is that there is no precedent for this level of distance. So how on earth is a midwife supposed to draw on experience to make that decision? You're putting them in a hugely stressful and untenable situation. We've only got, at the minute, about 60 births a year taking place in very geographically diverse units where a midwife will maybe only see one woman a year, if that, who is in the position where they're making judgments about transferal. So that resource of knowledge for the midwives to pull on and making that decision isn't there. So that's I think, is that the answer that, I don't know who asked the question. Is that the kind of answer that actually makes sense, maybe, to you? Okay, so my question is to Stephen and Rod. And Stephen, in your presentation today, you talked about how you want closure on this, and you want to move on, and you want to make a difference, and you want to make things better. And I totally understand that, and that's come up again and again. And I listened at length to the issues that you are struggling with, and Debbie explained the fragility of the services that this lady over here talked about, and how vulnerable everyone is, how stressed everyone is, and the pressures that people are under due to the fragility of the paediatric services and the risks that are involved there. But I have another report coming which looks at the implications of the international research for the impact on birth outcomes of the distance from West Cumbria to Carlisle if obstetrics care is removed here. And it shows that the risks there are vast and very toxic. So what that means for you guys as leaders of clinical services is that you are stuck in a situation where realistically the best way forward here is to keep patching up the systems, because the risks associated with trying to patch it up and keep it going and it potentially closing at times are much, much lower than the risks associated with closing it. So that puts you in positions where you are effectively running an underperforming service that's constantly criticised by the regulator. It puts you under huge personal pressures, and it's a hugely frustrating situation. So my question to each of the three of you is, are you really prepared to live with and defend that situation, and how will you cope with it?
Thank you. Thank you for raising that.
I should just say, I made some reference in my presentation. I think the work that you're doing and the fact now that we're having that engagement, I know there's going to be, we won't go into the detail, I know we've talked about it separately, a further piece of work, I think is all important. And it comes back to what Stephen's just been saying. I think we have to listen to the issues and the risks in the context that you're describing. And in your, this is all about the travel risk that you're referring to and all the detail of that. So I think we just need to acknowledge and thank you for doing that, because that's a very constructive piece of work that I think we have to listen to very, very seriously. And I think you're acting very, very professionally on behalf of the people that you represent. Having said that, I come back to, and to answer your question specifically, we will do everything we possibly can to provide safe services. So as a result of, if as a result of your research, we can find ways to actually mitigate against some of the risks that we're talking about, we will make it happen. I will make it happen. We know that the preference of this community is to maintain consultant-led units. That will be our preference if we can find a safe way of doing it. So I can give you an absolute assurance that we would pursue any constructive way which we can to preserve our services locally. I know we had this exchange at the door. The issue we've got with the regulator is we can't argue with the regulator. The regulator sets the standards. We have to meet them. And generally those standards are set by, not by the CQC, but by national and other professional experts in the respective fields. So we do have a particular challenge there, you're right, but our duty is to meet those standards. I'll pass over to Stephen next and on to Rod.
Thank you, Stephen. I think the Clinical Commissioning Group is very much aware that it's not going to be presented with a risk-free option at the end of the consultation when the recommendations come through. It's going to be a very difficult decision trying to establish which of the options before it presents the least risk and gives us the best chance of providing the highest quality service, in this case, to the women of West Cumbria. So that's why the consultation period is so vitally important, because it is absolutely going to inform that final decision. And the final decision, that final option, may look different to the one that's in the paper today. We have very open minds in that respect.
Rebecca, you spent 2.5 hours, I think, in what you described as a hot, sweaty office in the Trust, working through the figures. And I think this is the sort of debate and dialogue. You also described the difficulty of trying to staff on a continuous basis and provide a safe service. So I think you're right, there are these dilemmas, and we have to, with consultation, Stephen's described it, the Stephen next to me described it, that we have to, at the end of the day, make a decision that makes our gets that balance between what you describe as the travel risk versus the continuing to patch up the service in a way with variable quality of service delivery. So it is a dilemma, and one which exercises certainly my mind in terms of the medical director and the brief of really being responsible in part for the patient's safety. So yes, it is a dilemma, and yes, this is a difficult decision to reach and attain.
Thank you. Anything else to add to that? No, thank you. Thank you very much for that. And a really well-made point. I'm going to go to the back there, that lady there, to this gentleman, and then we're going to come over to this side, and then I'll come back to the middle.
Hiya, I work at West Cumberland on the admissions ward, and we get lots of patients that are admitted with query stroke. So that means there's going to be, the criteria for transferring the hyperacute strokes. There's going to be lots of people that are going to be sent up the road to Carlisle, the query stroke, which is going to have an impact on transport, ambulances. Not only that, the recruitment of acute physicians, if you haven't got all the services, how are you going to attract? So if you're only doing half a service, how are you going to get all these new doctors coming to work? If you're not offering a full package, it isn't going to be very attractive to come, is it?
Thank you.
And if it's a confirmed bleed, then what will happen to that patient?
Okay, Martin. Yeah.
In the hyperacute
right.
unit.
Yeah. So I suppose the hyperacute unit is there for several reasons. First of all, just to make a comment about stroke management. Stroke management starts from the point of recognition of the symptoms through to transport and through to now a range of very specialized interventions, particularly with the point of view of in about 10% of strokes now being offered in some areas of the country, and we need to reach and attain those standards where you actually remove the thrombus. Now, this requires an incredibly specialized group of people who've learnt to do that technique, a bit like the situation with heart attacks and PCI. So it is becoming a lot more specialized. And in terms of the bleed side of things, which is another variant of stroke, some of those are suitable for transport to Newcastle, where they get specialist neurosurgical intervention. And so there are a range of services which are improving the outcome from stroke, and a lot of them are highly specialized. It's not just about the initial management. I don't know whether that helps explain it, but that's the improvements in stroke management.
I think, though, if a patient needs thrombolyzed and they live south of Whitehaven, so by the time they've got to Carlisle and they're waiting A&E to be seen, there's a very short window that thrombolyze can happen.
I know. I'm going to agree with you about that, but that's not the way the model would work when it's up and running, because obviously you'd be putting extra steps in the process. And what I wanted to come back to in that context is your very well-made point about recruitment. No one is going to come to a very small single site, whether it's Carlisle or Whitehaven, stroke service. Strokes networks are the way in which we need to do this to save lives. So our stroke network is Newcastle, Carlisle, Whitehaven, and actually Preston, because already in Whitehaven, as you may well know, our stroke physician links directly with Preston through telemedicine. So both of our hospitals are going to be involved in stroke management. And if there is an acute stroke, a stroke can happen to someone in a hospital bed, can't it? Just as well as coming into your admissions unit. What we would have is a broader response to that patient. If you can treat the patient locally, fine. That might be something you would do. Thrombolysis is relatively straightforward if you're I think as far as I know, in a hospital setting. But these days, new technology, particularly the specialist technology for brain attack, as it's called, will mean that 10% of the people that we currently treat across all of our stroke population here will go to a specialist centre, because that is, thrombolysis won't solve that problem, but that specialist treatment in the stroke centre in Newcastle will. So you're absolutely right. If things were to happen in a way that's fragmented, or you're taking lots of steps, it won't work. But that's not what the proposal is. And we can spend a bit more time. And you asked the question as a member of staff. I'll try and make a point of coming down and explaining to you in a bit more detail how it will work. And your job and what you're doing is a vital part of that service in the future.
Okay, thank you. Can you just move on to the gentleman here who's been waiting? And before you get to it, I must apologise for misinterpreting your point earlier about the questions.
Hello, I don't work in the NHS. I'm a resident of Whitehaven, so it might be refreshing. So I'm going to try and use some of my expertise now. I listened to some of the comments, and the thing that really strikes me is some of the trivialisation that I hear. You talked about not being able to run a maternity unit with 0.8 of a consultant, but you seem to think you can run a maternity-led one with one ambulance. So what's the difference? And I would just like to say, if the ambulance is already in Carlisle, what are you going to do? And secondly, it's even worse if it's halfway to Carlisle, because it's still got to get there and come back. So that's one of the trivialized. I work in a different industry, and business continuity, disaster recovery, all those things, and you don't do it with one. You can never do disaster business continuity with one item. It works with a consultant, and it works with an ambulance. So where you're going to put the ambulance, and if I have a heart attack, I would expect that ambulance to be used to take me to Carlisle, not sitting there waiting for a baby that hasn't been born yet.
Thank you. Going to ask Matt to take the question.
Yeah, very good point. And I think the model as it stands at the moment, and as we've emphasised throughout, these things can change, but the model as it stands at the moment that we're looking at is a dedicated vehicle for the maternity. So in terms of your heart attack, if somebody has a heart attack in the community, that vehicle is purely for those transfers, and that wouldn't get involved. So what would happen there is within the guidelines as they stand, and we're still working on them, we would anticipate that if that vehicle goes on a transfer, it would be out of the equation for 3 hours, because you're looking at transport in both directions and unloading patients and all the rest of it. So whilst that vehicle is away, we would look then for the local vehicles that are within the usual mix to transfer the next patient.
Cover for it. Well,
in the unlikely event that 2 transfers are required from maternity at the same time, yeah.
So you've all got to queue up and make appointments for getting pregnant, ladies.
Yes.
I'm really sorry, and I apologise to you if you think we're trying to trivialise that comparison you make. No, I know, but I mean, I think it isn't trivial, and I think it's important that we just acknowledge if you feel we're doing that, then we don't intend to. But I think it's important to say that just on the specifics, and I'll come back to another important point behind what you were saying, on the specifics of the dedicated ambulance, as I understand it, as Matt's just explained, the ambulance is dedicated, and it's important to understand that the reason we're doing that is if in the event you end up moving down the road of option 2, and we need to understand why we're moving down the road of the option 2. There's some of our midwives in the audience, and a number of I don't think there's any consultants here. If you said to them, if we couldn't have a consultant-led unit, what would be your preferred option? They would say, we think it's better to have everything in a consultant-led unit. Now, what we're trying to do in listening to our staff and our community, and particularly this community, is provide an alternative, which is the midwifery-led unit, so some people who have a natural process of having a baby can have that locally. That's the rationale behind it. So actually, we should really try and support the idea of an ambulance, because what that's doing is supporting that local choice. And the intention is really clear that you wouldn't have that ambulance operating in any of the other emergency areas. On the point about transfer, this would be true in our institution, but there are 40 standalone midwifery units in England in total at the moment. And they operate these types of services over varying differences. I always make this point. Cumbria is not entirely unique. There are other parts of this country with the same distances. I accept the criticism about the roads, and that's, I think, an issue for local politicians and everybody else to make the case for that, because that clearly would improve everything. But the point about transfers from maternity-led units is the vast majority of transfers are for pain relief, and you can plan that, and it doesn't need to fit in the timescales that people are talking about. There is a risk that you could have a serious emergency, but all of the evidence points to that risk being extremely low when compared to some of the other risks that we're running with now and potentially in the future. So I think it's important to understand why we got to that position and why the dedicated ambulance and all that goes with it is in place.
So my point isn't about the changes that you want to make to the service. My point is about the trivialisation about the ambulance. It just doesn't work having a dedicated ambulance.
Well, I think it does.
It does not.
Well,
Yeah.
well,
Sorry.
let's not get into an exchange whether it does or doesn't work. I think one of the things that Anna mentioned earlier on, and I think it's because of the important point that you're raising, we have people looking at the use of the dedicated ambulance somewhere else right now. And obviously, I come back to my point earlier, if we felt the dedicated ambulance wouldn't work, then we wouldn't do that. We'd have to look at alternatives.
Well, listen, thank you. Your point's really well made. Completely understand it, and you're talking about safety. Yeah.
A trivial point.
So I think we're going to return to that. However, one of the points I would make around the whole purpose of consultation is that there's a number of options being presented, and tonight is to get your point of view to make sure that those options are fully discussed, and also to give the panel, who've been through a lot of stuff, but also to give them sort of grist to the mill in terms of their thoughts. So the options may change as a result of this. I'm not going to say they will, but they may change, and your points have all been very well made. I'm now going to throw over to here, and we'll return to you. I recognise the people, but there are people over there who've been waiting for some time. There's a lady there with this, again with the scarf, apologise, but she's been waiting for some time.
I've got several questions. So my first one want to be that how hard have you actually tried to get a consultant to help support the team at West Cumberland for the midwifery unit?
First question is how hard, yeah?
Yeah. Obviously, I'm a woman who is planning a family, and God forbid we do go for the midwifery-led unit. What are the timescales for implementation? Because this scares me. I don't want to be going to hospital low risk, and as the example this lady said, within 20 minutes her baby had to come out. My family know what it's like to live with a stillborn baby. For you, it's just a statistic. For families, it's emotional. It's for their entire life. Okay. How do you deal with that?
Thank you. Have you another point to make?
I think that's it. Providing on what they say back.
Yeah, no, thank you very much for that, and I really appreciate your honesty. So, I think first question is, how hard have you tried to recruit a consultant?
Sorry, I was just debating your second question. On how hard have we tried to recruit a consultant? Well, we've been trying to recruit, and I assume you're talking about the paediatric consultants, if I could just clarify that's what you were talking about. We've tried to recruit, in my time here, which is over the last 9 months, paediatric consultants. Every month there's an advert in the local and national journals, for specialist journals. So we're doing it all of the time. It's not we do it and then we do it again. It's actually out there all the time. In addition to that, we are recruiting internationally, and we have been able to appoint, albeit this consultant is going to work between Carlisle and Newcastle. We have been able to appoint, because there are vacancies there too, we've been able to appoint a Romanian paediatrician who will join us in about 2 months' time through international recruitment. So we are doing it all of the time. The fact is there is a national shortage of consultant paediatricians, and we come back partly to what Rod was saying earlier, that young paediatricians coming into practice want to work in an integrated model of care. By that I mean you have to look at the 2 hospitals and our community paediatric and children's service as one and recruit consultants to that. And in the future, my expectation would be that those consultants will work across all of those areas of care. That's the route to the future, and that's what we're trying to encourage people to do. And that's the vision behind the specific proposals that are in here. So that's the issue. But this came up last night, so it's worth saying that what we're going to do is publish on the website all the detail of all the recruitment that we've done, so you can see that very specifically, the evidence that supports that.
So the next question was around the timescales for implementation. Which Stephen's going to take that one?
I think on the point about timescale for implementation for midwifery-led units, it goes back to what I was saying before. First of all, we have to get to a point whether that is actually the option that's going to be pursued, and it's going to be next spring before we get to a point of, I think I'm right in saying, before we get to a point of decision making, something of that order. If that option was chosen, the timescales are going to be, in my view, I think what you would do is set up the midwifery-led unit alongside the existing unit, if you could, and it would probably take something in the order of about 12 months to move towards that model, because you would need to spend quite a lot of time within that period also preparing and developing our staff to support that new model of care. So it's like I was saying earlier on, we will be required, and we haven't set out a detailed timescale, because if you did, you'd say you've made your minds up, you've made a decision. So we haven't done that. I'm just giving you my personal view. But we would have to set out a timescale as part of the response to the final decision making on consultation.
My point about how for a dead baby for you is just purely statistics in your papers. It's money, that's it. But for a family, it's emotional. It is traumatic for their entire life. My sister was stillborn. I grew up with a parent who felt guilt until she passed away last year. So how do you deal with that? If you've got emotional teams in to support patients, families, the midwives who know that they're going to send a woman potentially in an ambulance who needs a crashed grade 1 section, putting her life and the baby at risk, are you going to emotionally support them?
Thank you. Can I, just from a personal point of view, my wife has had a stillborn baby, so I know exactly what that feels like. And I think none of us regard any of this as statistic. We share all the concerns you have, and what we're trying to do is to provide the safest possible care that we can.
Thank you. So, sorry, there's another point you're coming back with about support for family and staff. Yeah, thank you, Anna. I'm just going to take that.
So we already have a dedicated midwife, a dedicated bereavement midwife, and we also have a dedicated nurse for bereavement services as well, and we're expanding that team and going out to advert currently to have a dedicated bereavement unit at West Cumberland Hospital and at Carlisle. The work has been done, and we're just waiting for the furniture to be delivered. As for supporting the staff, we're looking at introducing Schwartz rounds, which are a supportive measure to support staff when they've gone through difficult times. And we use our occupational health services to do that as well, with counselling available. And, you know, our senior midwives support staff every day when they're on the job.
Okay, thank you. Really important points being made tonight. We're getting into the last half hour of the consultation, so I'd urge us to get through as quickly as possible to make your points, but I'm not trying to cut you through. So we've got a lady who's been waiting here, as a gentleman, and another lady here, and then I'm going to go back over here.
I've got a question for Stephen Ames. You stated before that you already have patients going to Carlisle for appointments. Can you tell me how many of those go because they believe the service isn't available here to them? Because recently I had to phone your office and refuse point blank to take my child all the way to Carlisle for it to be sorted out. And I have a question for the ambulance guy. Do you seriously believe that 2 people being transferred at one time is an unlikely event? Because I can tell you it isn't.
Two well-made questions. First to Stephen around patients, use in the appropriateness of the areas, and then we'll go to Matt around the question.
Yeah, I mean, Siobhan, I mean, on your particular personal experience, we should talk about that outside the main public meeting. I'm not going to go into that, which we can do. So I understand that. I think on the point about, if I understood it correctly, on the point about people going backwards and forwards to Carlisle, what I was trying to explain in the presentation is that there are lots of episodes of care that go on that might involve people like yourself taking your child to Carlisle, an elderly person taking their wife to Carlisle for things that they don't need to go to Carlisle for. That's because the way in which some of our services... if you let me answer your question, I respected your question. Let me answer it. Please, and don't interrupt me, or else I won't be able to answer it. So, what I was going to go on to say was that our plans are to bring all that care that's currently happening, that doesn't need to happen in Carlisle, back to Whitehaven, back to the West Cumberland Hospital. And furthermore, we haven't spent a lot of time on this. I know we talked about it a little bit earlier on. That's exactly what we're planning to do with the integrated care communities to bring care that's happening in the hospitals even closer to your home. So what I expect for a whole range of conditions, if I think about the model that the paediatricians and the specialists in children's services are talking about, in support of assessment centres need to be fully integrated services with the community and the provision of care to home for your child, so you don't even have to leave your home. That's the sort of thing that we're trying to do.
Before I hand to Matt, I'd just like to take the heat out of the room and remind everybody that I asked both colleagues and the audience to respect each other's opinions. It went past me then, but I won't let it happen again. Please respect each other. And that goes both ways. Matt, please.
Yeah, in terms of the number of transports, I don't think, I probably didn't make myself clear there. The dedicated ambulance vehicle is purely for the maternity transfers, and those are the ones unlikely because of the nature of the patients that...
Sorry, can you wait until we finish, please? I've just made the point that we're respecting the responses.
In terms of general transfers, yes, there are regularly more than one transfer at a time, but those aren't dealt with by a dedicated vehicle. They're dealt with by the general ambulances that we have in the area.
Okay, thank you. There's a gentleman behind you there. Ask.
Hello, we've just heard about all the concerns of the people, but I don't know that people have remembered that you said right at the start that by 2020 you'll be 163 million in debt. Now, if you were Marks and Spencer, you'd be shutting the shop altogether. So what I want to know is what should the government be doing to help finance the National Health Service so that you can do the job that everybody here wants us to do?
Okay, thank you. So there's a shortfall in the funding. Not necessarily of local making. I'll throw it over to the panel.
I think it's a point that's been raised at every single public meeting we've held so far, the issue of what is the appropriate level of funding that our health service requires. And we wouldn't be any different to you in wishing to see more investment in the NHS, of course. But nor should we kid ourselves that we can afford to wait for that to change. It's our job to try and find solutions within the resources we have. And that's difficult, as you've already pointed out to us, and we are painfully aware of that. But we share your passion for our NHS to be appropriately funded.
Thank you for the question. So there's a lady there who's been waiting.
I may be wrong, and I'm happy to be corrected if I am, but my understanding was the only reason that the maternity services are on the consultation document is because we've got a lack of paediatricians. It's not the consultant grade or the mid-grade doctors for the births that's the issue. So my query is, with the level of consultant and middle-grade doctors we've now got at the acute, why can those not be trained in newborn resuscitation if that's the only reason that we're having to have that option on there in the first place? I mean, I work for the NHS and I can't understand it, why a consultant can't be trained in newborn resuscitation. And if that's the only reason that option's on there, I think it needs to be explored further.
Okay, thank you.
Thanks for that. There are a range of people who can be trained for neonatal resuscitation, including some advanced nurse practitioners, and certainly that's a model that is operated in some hospitals in the country. They are a shortage supply. I think the difficulty we're all battling with in this is that actually some of these skilled individuals are a shortage supply, and actually neonatal resuscitation and pediatric resuscitation are, believe it or not, very specialized skills. And certainly if I was to say to a lot of our adult physicians, for instance, who might be the only person available if there's no pediatrician, you know, will you do neonatal or pediatric resuscitation? It is a skill that they don't have and wouldn't profess to want to have. Yes, you could train them in general skills, and certainly the anaesthetists and others on the site, which is the model we're looking for instance, the combined medical workforce, certainly some of those will be able to initiate first-line resuscitation. But it's a point, and it was considered in some of the options for for instance, not having a paediatrician on the site.
Thank you. Thank you. I'm going to send you over there. There's a lady that's been waiting there for quite some time.
Hello, my name's Laura and I work at West Cumberland Hospital as a physiotherapist. I just want to stress to everybody before I actually ask my question is that I know there's a lot of focus on maternity services at the minute, but don't lose the sight that there is other services being lost because we have seen maternity being used as a smokescreen in the past. So if you could ask questions about other services as well. And my question is about intensive care. So I just wanted to see, in your consultation document, it says that we will have a small intensive care unit at West Cumberland Hospital. Well, actually, there's only 6 beds there now. So what do you constitute as small? And also, it says underneath, the most seriously ill patients will be transferred to Carlisle. Well, I wasn't under the impression that intensive care was for very seriously ill patients. So what will our West Cumberland Hospital intensive care be used for? Yeah, that's my question.
Yeah, thank you very much for that. Hand over to Rod again.
Thankfully, one, I do feel on home ground because I do intensive care and work between the 2 sites, and there's no intention. In fact, the intensive care unit at Whitehaven is a very modern design and essentially is about as small, the 6 beds in terms of high dependency and intensive care, about as small as we would run now. Generally, we're talking 8 and upwards, but the model at Whitehaven, I mean, in technicality, is also combined with the next door coronary care unit, so it's considered more of a critical care unit combined.
Yes, the question is about...
What, are we planning anything?
No, what constitutes seriously?
Oh, to stay, sorry, I've obviously missed the point of the question. Can you just...
I just want to know, are the beds going to reduce on intensive care? From 6, are they going to reduce down? Because it says in the document that it's going to be a small intensive care unit.
You also asked a question about the definition of what makes...
Seriously ill, because...
I think Rod's answered the bed question, but what defines seriously ill?
Well, seriously ill patients to me is anybody on intensive care. So if the seriously ill patients are getting transferred to Carlisle, then what is our intensive care going to be used for? And if the seriously ill patients are getting transferred, then we are losing vital skills at West Cumberland Hospital. I've worked there for 7 years as a physiotherapist. I've got respiratory skills which I've learnt over the years from my colleagues. But actually we've lost quite a lot of new Band 5 physiotherapists who have left the area because they want to get skills that we don't have anymore, simple skills that we don't have at West Cumberland because respiratory patients are getting transferred.
Okay.
So I myself am considering leaving, and I've lived here. I've been born here. I'm
Sorry, I don't mean to
loyal.
cut you off.
I'm loyal to the area.
It's a great point. I want to allow Rod to come back in.
Yeah, so I
don't
just
want to cut you off.
about retention, really. So
Okay.
just if you can't keep me, who's loyal to the area and who's lived here all my life, how are you going to attract people to come?
Thank you, Rod.
That's fine. So the intensive care unit is not reducing from its current size, nor its current bed occupancy. So it is inherently, because of the nature of the mix of patients that come through there, and the fact that the intensive care in Carlisle tends to take more of, because of the cardiac unit and things. So the mix between the 2 units is different, particularly as we've moved the general surgery complex cases to Carlisle. But there is no intent to reduce the numbers of intensive care beds, the numbers of admission to the intensive care and their mix between really critically unwell and the lesser levels of ill health. They have not changed, and I can talk to you later about the evidence for that.
Thank you very much for that. Some well-made points. The gentleman here has been waiting.
Hiya, my question is, I didn't hear the answer before. How are you going to get mother and baby to Carlisle within half an hour in an emergency? The 6 years there, please just answer the question.
the question's been asked. I think it's been answered, but I'm going to ask the panel to just clarify the thing. Yeah. Well, yeah.
Okay. So I think I said earlier, the call to have a 30-minute caesarean section would not be made if we were a midwifery-led unit, because we wouldn't have a consultant there. Our midwives would use their highly experienced skills, and they would be risk assessing the woman and moving them into the dedicated ambulance vehicle at the earliest opportunity. So we would not be able to call a 30-minute caesarean section because only an obstetrician can do that. So it's about using the midwifery skills to identify that there is a problem with that woman in labour and initiating the transfer.
Sorry, there's a couple of points going on there. Yeah, no, I think the question is very clear. How do we get to the 30 minutes? The answer clearly doesn't satisfy the audience, so it needs to be something that needs to be considered in the options. So that's a point well made, and because the evidence is here, it's included tonight and will be considered in the options. And thank you very much for clarifying that point. So we've got some more questions. I'm going to throw to... Yeah, well, let's go right to the back. These two gentlemen have been waiting for some time. Then I will come back.
Thank you very much. I like this gentleman. I'm not part of the NHS. I'm just a member of the public. But I would like to invite Anna to publicly apologise to every single midwife that she's offended. She's offended them by the way in which she said that they're not professional.
Sorry, before that, are you a midwife?
I'm not a midwife, no.
So how can you speak for midwives?
I'm speaking on behalf of the fact that last night, in public, she suggested that the midwives needed further training because of issues that you are causing as part of this consultation.
Okay, that's clear. Okay, so I understand your question.
That I'm a midwife.
Yeah, I understand your question now.
I made it clear what I was.
Yeah.
That I was not representing midwives.
Fantastic. Okay,
I'm asking the question. The question is, you should publicly apologise for what you said last night.
Sorry, sir, that's not a question. That's a statement.
It's a question. I'm asking if she will. And then I would also ask if you will again apologise for what you've said this evening to suggest that midwives should use their hands and their eyes, because what you're saying is when it goes wrong because of the inadequate services that you're offering, it's their fault.
Thank you.
And I have one further point, if you don't mind. I would like you to publicly publish the risk assessments that you have done in relation to transferring pregnant women from Whitehaven, from Wadsdale, from Gosforth, from Seascale, from Milham, that suggests that you can get them to Carlisle in a safer manner. Shows the risk assessments, because I don't think you've done them.
Okay. Thank you. Some well-made points. Okay, so I'm going to throw to Anna.
So I think what I'd like to do is clarify what I actually said last night. I can't recall whether you were in the audience. What I actually said was that midwives are highly skilled practitioners, and we receive training all the time around emergency cases within maternity. And as midwives, we do use our hands and our eyes and our ears to identify when there are problems with women. I definitely said that the training would be given to midwives if they required further support. Our midwives already receive multiple amounts of training on a regular basis to deliver safe care now, and that won't change.
On the point about risk assessment, they are going to be published. And I come back to mine, were you there last night? That we covered that in some detail, and we did in other meetings as well. And in fact, if you have access to the website, or indeed if you want to personally receive the information, just leave the details with us, because there is a massive amount of research that has been done over the last 2 years under the auspices of the Royal College of Obstetricians and Gynecologists. You're more than welcome to see all of that, because I'm sure you would understand that we wouldn't be putting forward propositions and ideas that doesn't have expert support and opinion attached to it. I come back to my other point, which is really important to understand. Travel is one risk. Not having a paediatrician available when there's a complicated delivery is another risk. These are the things that we have to work together and understand together. So when we publish risk assessments, it won't just be about the roads, it will be about the other risks that we're facing in providing services now. And my plea to everybody here, beyond the passion about this, which I completely share, is listen to the different risk issues that we're trying to balance and manage, as Stephen was saying. And I'm sure that'll be central to the outcomes of the consultation. I must just finally say, I was there last night. We have a very professional person sat next to me who didn't say any of that, who didn't insult any midwives, who in fact is very supportive, as I am, of our midwives. And if you're in a room with them all, and not just from West and other areas, they will say we don't have the skills, many of us, to run standalone midwifery units. So what we're saying is, if we were to go down that road, then we'd need to extend our training and development opportunities for our midwifery staff.
Just to come back on that point, because it's relevant, very quickly. What was said was, I see this as a huge opportunity. It's about having the experience and skills to practice being with women. We'll provide more training. So what we're saying is that the midwives that we've got in West Cumberland, which in my opinion do a fantastic job, are needing more training, and that is absolutely untrue.
Fantastic, thank you. Thank you for entering that into the evidence. I don't want to get into a big debate about this, because this is a really contentious issue, and I think we can spend a lot of time. I've got a lot of people who want to add to it. Gentleman standing next to you, for instance.
Yeah, we keep hearing about the different areas of the hospital, but I think one of the key bits that everybody on that panel keeps missing is Cumbria. Cumbria is unique. It doesn't matter where you are in the county, what you do, you keep coming up with the community care programme, acute services, cottage hospitals. Year on year, roads within the county are blocked, be it through accident, be it through flooding, be it through snow. Yeah? We keep hearing people out in the community. What are we going to do out in the community when Mother Nature kicks in? Last year, December, yeah, we couldn't get out of West Cumbria. We couldn't get to Carlisle. Nobody could get out, either south or north, or on the 66. So where's the contingencies? You know, we're looking at moving everything from here, closing some of the cottage hospitals, everything up to Carlisle. Where's the contingency plans when things don't go to plan?
Okay, thank you, sir. So it's an issue we've heard a lot about, the roads, and I'm going to ask the panel to respond.
Just a simple answer on the contingency plans. They exist, and they operated tremendously well when we had all those pressures last year. And as a result of that, I'm very proud. I wasn't here, but I'm very proud of the NHS staff who made sure that the care that we offered during that period remained at the same standard, whether it was in West Cumberland or in Carlisle or in the community services. So we do have very detailed contingency plans, and the evidence is we manage very well. I don't come from Cumbria. I've got relatives who do, but I must come back to the point. Cumbria has its unique features, but I've worked in the southwest. They have many similar features. They also have road problems, significant road problems. They also have issues with weather conditions. And we are learning from those other areas, and they can learn from us. And that's how we want to work as a National Health Service.
Okay, thank you. Right, there's a gentleman there who's been waiting. Oh, no, we'll come back this way.
Could I just point out 3 points? First one is the only other place comparable geographically in the UK is out of Glasgow, so you can compare it to anywhere else in the UK that you want. The only other place comparable to Cumbria is out of Glasgow. Secondly, I have a concern that we keep on talking that no decisions have been made, but yet we keep on saying a plan is in place for this additional ambulance that's going to sit at West Cumberland. Why is the plan already in place if it hasn't been decided?
Okay, thank you. My third point?
And my third point is, I would like to ask the panel, I've spoken to many consultants that have now left the area just on a social basis and discussed why they're leaving the area. And it's to do with management issues with the consultants. You talk about recruitment, maintaining recruitment and recruitment and retaining existing staff. But yeah, I come to these meetings and all I can see is a big gap between management and staff. You don't listen to your staff. You've got consultants sitting here telling you they've got years of experience of being in this area. You've got staff telling you who've been in this area for 8 years.
Okay, so I don't want to shut you down, but I want to get at least one more question in.
If I just take the second part of the question, I think that the facts are, and we'll publish them, is that we've got more consultants this year than we had last year. We've recruited more across the whole trust, and that's clearly available information. So people are coming here, and we'll intend to do more of that. On the other bit of that part of the question, I think there have been lots of issues about how these services have been managed in the past. I can only talk about now. I'm the person in charge of listening to staff, of reacting to their problems and so on, so I take full responsibility for that. I spend many, many days in the working week. I've been in West Cumberland today, I've been in the operating theatres, I've been in the accident department, I've been on the wards listening to staff. And listening isn't just about hearing what they have to say. Sometimes it's about clarifying because it's not always clear, like the intensive care issues we heard earlier on. But sometimes it's about doing something about what they say. So I'm quite happy again to publish, as far as I'm concerned, the things that I am doing personally, specifically in our hospitals when staff raise them with me. There's clear evidence of that. Again, I think it's really important. It's the most important thing that someone like I should do. I think Stephen will pick up the first part of the question.
Just that's evidence, publicly made statements, and I'm a man of his word, so we hope. So thank you very much.
Could I ask you just to repeat your first question, because I lost it in between your statement and the second question.
Is that to do with the geographical spread? Yeah. All I'm saying is that Cumbria, as a geographical spread for vehicular response, is only comparable to out of Glasgow. There's no other part in the UK that compares to us.
Yeah. I think you asked a question after that, though.
It's about the ambulance service. No decision's been made, but we're talking about ambulances.
Oh, sorry, yeah.
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 It was about we'd already made a decision.
Yeah.
Yeah.
Okay.
Can you just repeat the question around the ambulance?
Sorry, it was connected to, I think, your second question. So I thought I took that as a statement about out of Glasgow.
It was, yeah.
I think your question was about plans already being in place and therefore decisions already been made. And I don't mind repeating myself. Genuinely, there has been no decision. There are no implementation plans. Stephen said it earlier, because in part we can't tell you how long it will take to implement because we haven't got the plans in place. Because the actual eventual recommendation and the eventual approved option may look very different to the ones that are in the document today when we take into account and independently assessed all of the things you've told us over the 3 months of the consultation.
It's just the panel did say, the words of the panel were, a plan is already in place. That was the words of the panel this evening.
I think that was with regards to contingency.
I think what we've been saying is, as part of this whole process, the ambulance service has been asked if that option were to go ahead and a dedicated ambulance were to be part of that plan, how would that work? So as our part in the whole process, the ambulance service has looked at that and is working with other providers who provide similar ambulances to say if that was an option, then how would that work? So the idea is we put proposals in place to say if that were to happen, then this is what it would look like. That's not to say that is the option, but if it were, then how would it look? So that's the kind of documentation that we're starting to work on. I have colleagues down in Wales at the moment who are looking at the vehicle down there to say if that was an option, exactly what would it look like?
Thank you. Right. So, yeah. It's clearly an issue that will be returned to, and it's something that will be picked up in all the plans. You've made your points very well. This lady's been waiting here, and I'm afraid this is the last question that I'll be able to take tonight. I apologise for the frustration that anyone may feel around this, and I will say that the panel is not disappearing yet, and we'll listen to what you have to say. But come back to the point before I let you ask your question. This document gives you all the ways in which you can take part in this consultation apart from that. Okay.
My name's Janet Cruz and I'm the midwifery manager at Whitehaven. The point I'd like to highlight tonight is that I don't think anyone has mentioned is all the work that we've done in maternity services already to retain and to recruit consultants, and the different ways of working that we've already put in place and how that model could be replicated in paediatrics, because it's been really successful. You know, Stephen, you've asked us to look at different ways of working, and we've done that, and it's quite successful in maternity, and that can be replicated in paediatrics, and I think there's work going on in that area already to make sure that, you know, that model can be replicated. So I'd just like to highlight that things are happening and it is possible.
Thank you.
Only to agree with Janet. I mean, basically, what we've said to our staff is if we can come up with proposals that are not in the consultation document that are workable, then we want to hear them. And now that's what you're talking about. We've got a big event, haven't we? I think it's towards the end of this month with all of you and others following on from those discussions. So we'll see where that takes us. Yeah, absolutely.
Right, thank you very much. I do really apologise for those people that have not had the opportunity to speak, but I will say thank you to the panel, but most importantly, thank you very much to all of you. I am, as always, humbled by the fact that you'll come out on a rainy Tuesday to discuss these matters and put your passion to it. So thank you very much. And the panel isn't going, so if you do want to talk to them, please do.